Alec out to being my parents' place back in Adelaide. So I just
Well, welcome everyone to this first NCIC symposium for the year. It's great to have everyone here, and it's fantastic to kick off with an excellent speaker today. I'd really like to give a warm welcome to Graeme Forrest. Now, Graeme is Professor of Medicine and Head of Transplant Infectious Diseases at Rush University, Chicago. He actually trained in Australia and is an Australian, but has been living in the US for many years. And besides being an excellent transplant ID physician and antimicrobial stewardship in transplant, his other talents are marathons. And you might like to know that he's recently completed 6 major marathons, but he might tell us a little bit about that in his talk. But he's actually had to rush to get here because unfortunately his flight was cancelled, and he's was on a very tight schedule to get here, but has made it. So it's a great pleasure to introduce Professor Graeme Forrest, and I will hand over to him now.
right. I can just into there. I'll just look at the screen. Yes, so just a little background. I wasn't smart enough to get into internal medicine in Australia, so it's much easier in America. And then I'm too smart for that. No, I'm not being facetious, but they've been great. So I did my infectious disease fellowship at the University of Maryland in Baltimore. So that is the home of Institute of Human Virology with Gallo and Redfield and that group. So that's where I started my transplant infectious disease journey. But at the time they were doing over 400 kidney, hearts, livers, lungs, and multiple organs, as well as their bone marrow program wasn't as big at that stage, but it was growing since then. And they were the first center recently to do the pig heart transplant about 2 years ago with that novel CMV virus that came out of that pig heart transplant that was put into a human. So it's a very innovative center. And after 8 years, I moved out to Oregon. So I was mostly VA based, but my clinical time was in the transplant service there, which the Knight Cancer Center, which is $1 billion was donated by Phil Knight, the owner of Nike, or the discoverer of Nike. He's giving away most of his wealth before he dies. And so they had so much money, they were doing over 200 bone marrow transplants a year, lots of CAR T when I left. And we were also covering liver, kidney, and we were doing a lot of HIV kidney transplants and bone marrow transplants. And then I moved on to Rush, and it's a 750-bed hospital in Chicago. It's on the west side. It's a big campus between Rush, University of Illinois, Chicago, and the county is right there. There's about 2,500 beds in that area. And they've got a big cancer center. They're ramping up their program with MD Anderson to do a lot more clinical trials. And so doing a lot of CAR T and stem cell transplants. And kidneys and livers are the other ones. We're the main center in Chicago doing the HOPE trial. I don't know if you know about that. That's doing HIV transplants for kidneys and livers to HIV patients. So on March 5th, I finally finished my journey of running the 6 world majors. So it was challenging. Tokyo is challenging, but they're the 6 world majors I've done over the last 7 years. So I think I can retire now. So I took it on because it's a good stress release. So I pretty much had this introduction. If people don't know, I'm the editor-in-chief for Clinical Microbiology Reviews, and so I've been getting a lot from Melbourne lately. So happy to help out and looking for always good reviews. So these are cases, keep in mind for later on. These are, I saw last on service about 3 weeks ago. The first one is a 29-year-old man who grew up in Mexico, who had a kidney transplant 6 months earlier, had received thymoglobulin for his kidney transplant, now has a new cough, hypercalcemia, and pancytopenia. And so this is his chest X-ray. I'm not sure if you can see adequately. There's all this ground glass and this large cavitary lesion. We look back in, he'd been treated for latent TB for 3 months before he went to his transplant. So that's him. And the same week, case 2, it's another Hispanic male who from Mexico who had a new diagnosis of acute myeloid leukemia. Was given 1 in 5 mitoxantrine and cytosine rabinoside. He is now neutropenic and on service is having severe headaches, and he's got now a trapped temporal horn on the left side. And so ended up having a brain biopsy to make the diagnosis because everything else was negative. But they both have the same disease, so you can tell me later what you think it is. Last year, I put together this large edition for transplant infectious diseases. So this talk is unique because there's really no data. And so, and it's it's sort of like a unicorn because no one really wants to tackle stewardship in transplant at all. And it's very frustrating. And to get data is really difficult. And so I decided with Shahid Hussain in Toronto, we needed to get more information out. So there's 47 articles in there. We did regions. We heard from all different countries. Some countries withdrew because they were worried about the consequences from their government of presenting data that's showing there's a lot of resistance, and they feel like it was being difficult. But we managed to get a lot of papers, regional papers, as well as some new ideas to tackle. And I'm going to bring in some of these ideas for this talk. This was Chicago 3 weeks ago, so it was 20 below zero and the lake was frozen. I was out running, it wasn't bad. So these are in the United States. I don't know what it is in Australia, so forgive me if I don't know. But for participation to get Medicare reimbursement, the hospitals have to pretend they're doing stewardship. They have to say they're doing it, but it's really, you say it, but you don't have to show much for it. And you have all these requirements, so leadership, accountability, pharmacy expertise, which means you have a trained pharmacist in antibiotic stewardship, taking action, tracking your interventions, which is the biggest problem because you can't get good data, reporting and education. But out of all this, there's not one thing on patient outcomes. And it's been my biggest frustration for 15 years is every time I say, well, we do this, but what's the outcome to the patient? And no, we have to do this, but we don't worry about the outcomes. And for immunocompromised hosts, it's even worse. It's, you know, we'd love to do things and interventions, but it's really a battle between us and the oncologists or the transplanters. It's to get, well, we like to do shorter courses, but no, we like to treat longer. And so we've got no data to support one or the other. And so transplant populations are special populations, as we know. They're more immune suppressed. Don't know what your multi-drug resistance organism rates are, but where I am in Chicago, we see a lot of bad gram-negative infections. And I'll show you one case I had just a couple of weeks ago. And of course, large amount of antimicrobials are prescribed. And a lot of preventative antimicrobials seem to want to be prescribed because they makes them feel better. And the durations keep going. And then because these centers are individualized, especially in the States, you can't get good collaborative data. And that's always a big thing, because it'd be nice to pool centers and have data so you could actually utilize, oh, we're doing this together. And then outpatient usage, we have no idea what's going on in the outpatient setting. And the input on the antimicrobial use varies by center, is often by prior experience. Well, I've always done it this way. You're going to have to follow my lead. And, you know, I've come into centers where that's the routine. And so what are the problems with the current ASP practices? So when I first moved to Rush, the stewardship program was telling the ID physicians who are on the transplant ID service where they could get restricted antimicrobials, especially like ceftaz, avibactam, or cefidericol. And so they would have to call the attending on the transplant team would have to call the stewardship person to get permission to use those antibiotics, even though we were consulting on that patient and approved it. And to me, that made no sense at all. And so these are things that make aggravating factors, and we want to simplify. And so it's taken me, took me about 12 months to break that down. I said, anyone who's getting the restricted antibiotics, we're going to see as a consult. And that way you don't have to interfere or make a problem. And it's worked. It has worked, but sometimes the barriers put out from the outside are not helpful on the teams on the inside. So I'll show you our team at the end. It's really well made. And often the goal for the hospital is to save money. And that's when I started stewardship, that was claim to fame as we save money. Again, no patient outcomes, but the hospital was happy. But I was always trying to move forward onto that level. And then we have the handshake rounds. If you're not embedded in with the transplant teams and you're coming in from the outside, yes, it's nice to meet and greet the teams, but you still don't have an understanding of the patients or the population. And by us being there as a team of 4, they rotate every 2 weeks, they know us, and we can say, well, let's try this, let's stop this. It gives a bunch more credence to have a built-in team to work with that. And then pre-authorizing antibiotic use, I just mentioned how complicated that is, especially for how sick our patients are, especially febrile neutropenia. And I'll show the case later to show you the difficulties. Prospective audit and feedback shown the major benefit to reducing antimicrobial use, and Miranda So from Toronto has shown that in their program. But again, yes, it's accepted, but there's no patient outcomes at the end. And as I said, most stewardship programs have no connection to the transplant programs, and these can be adversarial. And I've been in that setting where they're like, we want to do it this way, you don't know our patients. So immunosuppressed, what do we talk about nowadays? It was easier back when I did my fellowship in 2000. Now it's like, you've got all these biologics, which impact the immune system in so many ways. Like the BKI inhibitors, I saw so much aspergillosis in Oregon that we had everyone on prophylactic voriconazole, even though it did boost the levels. They were okay with that. Go to Rush, oh no, we can't, we don't like to do that because it boosts the levels. And so I've seen so much aspergillosis in the BKI patients, it drives me nuts, because we see something, we know something, but implementation is always the final straw. We know about TNF inhibitors, see a lot of listeria from that. That's the one thing we have to address. We've got solid organ transplantation, a lot of thymoglobulins, so they're immune suppressed for longer. We've got chemotherapeutic-induced neutropenia as a different beast to organ transplantation. And then allogeneic stem cell transplantation, and all the varieties from haplo to straight to mini MUDs and unrelated donors that bring in high complexity of immune suppression, and then graft versus host disease at the end. And lastly, CAR T is our new kid on the block that sort of throws curveballs at us. And had a really bad case of disseminated Mycobacterium fortuitum. It was in the bone marrow and the lungs and the brain from a CAR T case. So how do you define immune suppressed when it comes to doing stewardship? I don't know. So one size does not fit all. And what are the meaningful outcomes we want from being a stewardship? Is it antibiotic resistance? That's a good thing. So if we could reduce that. Clostridioides difficile, I don't know if you have a problem, but we have a problem. Is it survival? Of course. Is it readmissions? Of course, they're important. Is it costs? I don't think so, not for our patient population. We spend $1 million on a bone marrow transplant. We worry about spending $4,000 a month on a savuconazole from the insurance companies in the States. It's very frustrating. And then updated management strategies, that there's new data coming out, and how do we keep that up to date? So We do have a continuum for our solid organ transplant patients, but we don't really for our allogeneic stem cell transplants. As you can see, the patients with end-stage organ disease, they're very sick and they're as immune suppressed as post-transplant. And then you have a section early post-transplant where they're on OI prophylaxis, they're on surgical antibacterial prophylaxis, and then we run into durations for common syndromes. And then late post-transplant, when their immune system has recovered to a level, they should be treated as normal patients. Yet they often are treated as they're given peptides of vancomycin for every little condition, even though their immune systems, it's like pneumonia, should be giving ceftriaxone as their throat. So individualized stewardship it's how we do it. We, as I said, we developed a team approach. We have our group of 4 physicians on a rotating schedule embedded in the program. We go to all their meetings, we prepare all their guidelines, have the guidelines vetted, and we have a trained ID pharmacist who works with us, who rounds with us, who can help us know about drug interactions, allergies, delabeling allergies, which I do so frequently. And then we get to learn the antibiotic resistance patterns. We're trying to develop antibiograms for the cancer service and for the transplant service. The livers are much worse sometimes because they've been pre-exposed in the community to multitudes of antibiotics. By the time they get to us, they have these multi-drug resistant Stenotrophomonas, multi-drug resistant Enterobacters, and then we have to work out if we can transplant them or not. And then we have to utilize the current data out there. And then we do set durations. We have EPIC, which is the electronic health records system, a lot of cut and paste. So if you write, we'll do 7 days for something, 4 weeks later, you'll still see we're doing 7 days for something because it's just been cut and paste throughout the record. So I train our fellows when they're on service with us that we'll put an end date. It finishes on this day, or we will review it on this day. That way, we know that someone's actually looked at it and we can have that reevaluated. Doesn't mean it has to end, but it can be reevaluated. So this is sort of our model. We have the stewardship program, we have the drug reactions, toxicities, team guidelines, durations, prophylaxis, antimicrobial resistance. There's all this other noise on the outside. Cost containment, the hospital's big on that. Antibiotic days of therapy, I do not know how to apply that to our patients because they're all wrong. Diagnostic stewardship, again, how do you apply that to our patient population? Can you not send out for HHV6 for our allo stem cell patients when they're becoming confused and hyponatremic? And then data analysis is one of the big factors we always run into. Where do we get the data from? And Carlos is in that. But I think the most important thing is all this has to be focused on the patient. And I think as any good steward should be, how can we make the impact of what we do better for our patients? So we do know that it's well received, but I have a dubious view of this. As you can see, the interventions most preferred are bedside rounds, but most stewardship programs are too stretched. If you have a 750-bed hospital with 150 ICU beds, are you going to come up to the cancer center to do bedside rounds unless you have a team up there? So it's very difficult. And the least preferred, and I agree, is restriction policies. And so we've really set out to make it easier for them to at least get 1 dose up front. But even then, we run into barriers from temporary people on shifts. And I love this slide because it highlights, this is Susan So at Memorial Sloan Kettering. These are acceptable things. But when it comes to outcomes, everything's like high 70%. Love it. They love the education, dose optimization, less likely prior authorization, IV to PO. I can't believe in 2023 we still have to discuss IVWO. We know this has been a good thing for a long time. Antibiotic cycling, but when it comes to outcomes, it sort of drops off considerably. You know, we do all this work, we don't have outcomes. I'm sorry, honey. I tell you, I've inhaled a lot of dust the last few days, and my allergies are really bad. So Hayley's our AD pharmacist. So, oh man, she does a great job, and she can get us our broad spectrum antibiotics, expensive ones. So cefiderocol is $1,500 a day US. Do you have it here? Okay. It's for our multi-drug resistant Pseudomonas, Stenotrophomonas, and Acinetobacters. We have a pharmacy and therapeutics committee. And so she helps put our submissions through there for anything guidelines and things. This is a hospital-based requirement. Patients and renal replacement therapy, she does all the dosing for us. And then she's scanning things for unusual antimicrobial combinations, and I'll show you one in a little bit. And she helps us insulate us from the general stewardship program. One thing we're targeting is vancomycin usage. Sorry about this. So we're still using guidelines from 1995 for vancomycin for the empiric use in the hospitals. I went through the rush when I moved there because everyone seemed to get vancomycin. And I was looking, and there was one nosocomial spread that I could find in the infection control in 4 years. Yet 100% of patients getting vancomycin. At OHSU, there was 2 cases in 10 years of nosocomial. And at the VA where I work, we didn't have any for 15 years. And so we worked hard to get rid of vancomycin at our 2 hospitals empirically for nosocomial, not from in-house hospital spread, not from coming from the community, not coming from a nursing home. But in our ICUs, there was no spread. In our floor patients, no spread. Yet it's still a must give. Yet we're running into incredible toxicity in our allo stem cell patients with kidney dysfunction because they were still dosing based on the 2009 requirements. And then the AUC MIC implementations are very complex, and you have to have nurses drawing blood at the right time. Otherwise, it does not improve outcomes. So this is something we're targeting right now. And this is from MMWR showing the decreases in MRSA over the last 10 years. It's even gone further down, even through COVID. A lot of hospitals stopped testing for MRSA during COVID. I don't know about you, but we just don't see it as a nosocomial spread anymore. We see a lot of ESBL, E. coli, and Klebsiella. That's gone up like crazy. And so Dr. Santos, who I work with, he's developing a new way of measuring these things, and it's called the antibiotic use in the hospital to the antibiotic resistance ratios. And if you look at our antibiotic use for our daptomycin or nasally, the value comes out about 2. And if you look at our VRE, it's 1.1. So the ratio for those 2 is very low, it's around 17. If you look at vancomycin, it's 43 for the antibiotic use for 10,000 days. So, yeah, per 1,000 days. And this is per 100,000 days. So you're giving like 200 doses of vancomycin for every 1 MRSA presumed infection. I have better odds with the lotto, I think. So these are things that we can target. We're much better with meropenem-free ESBLs because we know we're seeing a lot more of that. And we've had to change our profile, gone away from cefepime to meropenem. Unfortunately, it's creating a problem with Pseudomonas because meropenem is very weak against Pseudomonas a single point mutation. We're just seeing the rates of meropenem resistance to Pseudomonas going up. So there's downstream consequences. You do one thing and something else happens. It's very frustrating. I know you don't do organ transplant, but these are some of the targeted stewardship interventions. When I got to Rush, they were doing 7 days after wound closure for their liver transplants. I'm like, why? If it's closed, if it's going to get infected, it's going to get infected. And if antibiotics can't stop the effect of corticosteroids on wound closure and healing, but they seem to think so. And I showed that it increased their C. diff infections. If they have a contaminated infection, sure. We're doing a lot of stop checking urine cultures. That's been a big program for us for a long time. And then we're setting durations for real infections based on the current data. So we're doing 7 days for gram-negative rod bacteremia on all settings pretty much. And don't believe the penicillin allergy. I'm very big in removing the penicillin allergy. It's, everyone gets a penicillin allergy put in their chart. It's like a zombie allergy. Even if we take it out of Epic, if they go to an outside hospital that has Epic, they'll see that it had a penicillin allergy before and put it back on. And then they'll come back to us, even though it's been delabeled. It's one of those things that we just can't kill. And then I've already mentioned that. And then using biomarkers. We don't have biomarkers for our antimicrobial usage, but where I was in Portland, we used a lot of procalcitonin. We use it properly. And so it makes a big difference because you can actually trend it very quickly and stop antibiotics a lot sooner. I thought I'd give us a call out to our paper in CMI, clinical microinfections from last year. We talked about a lot of these things, the impossible dream of, can we do shorter courses? So it's a patient I just saw, a young lady, about 41, with severe alcoholic liver disease, with bad cirrhosis. She had a liver transplant 4 days earlier, was given a gram of sodium medrol as an induction. She'd had a prior gastric banding for obesity like 4 years earlier. Well, that just eroded through the stomach from the steroids and her ascites. And then so she had VRE and Candida peritonitis. And so I came on service in about mid-February. She'd been on micafungin and high-dose daptomycin. So how long should we treat? I have no idea. This is the complexity of the patients we deal with. It's a secondary peritonitis because she's already had a surgery, and it's really tough to treat infections. So I put down, let's do February 14th based on her clinical condition, and we can revise. She kept getting sicker, so we had to extend it out longer and longer, but at least at least had a plan. She did develop daptomycin resistant VRE and micafungin resistant Candida albicans by the end of this. But you can't win sometimes. You've got a very sick patient, but how do we reach a point of when to know to stop? And I don't have that answer. We need better metrics, we need better testings, we need better biomarkers. And this is the 7-day for gram-negative rod bacteremia studies. The YAHAV study was the main one that was presented at ECMID in 2018 and then CID in 2019. We went through 23% of the patients were on some form of immune suppression and 8% were solid organ transplants. And even then, there was no increases in relapse of bacteremia and no differences in mortality. And I'd rather relapse bacteremia while they're in hospital with something I can treat than something that's much more resistant. My other big battle that I'm losing terribly is fluoroquinolone prophylaxis in febrile neutropenia. I don't think I'll ever get this off in America. This is like the proverbial crutch for all our oncologists. Yes, I understand on the outpatient side, but on the inpatient side, it makes no sense to me. It's easy and convenient. It helps with the outpatient, as I mentioned. I remind them it's the only antibiotic that alters bacterial DNA. It's a DNA gyrase inhibitor. It's actually the one that directly impacts increasing ESBLs. And I think it's why we have such a high rate of ESBLs. In Portland, we had a tie between the carbapenem-resistant Pseudomonas and fluoroquinolone use. It was levofloxacin resistant, meropenem resistant, 98%. And that was just in our cancer center alone. And I know it was just driving that, and they actually confirmed it just last year. And then when they do get septic, it's always our streptomyces infection. So they're in hospital, they're on a fluoroquinolone, they get fevers with their neutropenia, and they're on a fluoroquinolone. You're going to change the antibiotics. So why do we need them on the fluoroquinolone in hospital to begin with? I don't understand. And this paper sort of is a meta-analysis. Yes, fluoroquinolones do decrease bloodstream infections, and they do decrease fever, so that makes everyone feel happy, but it has no impact on mortality or outcomes. I'd rather, while they're in hospital, not be on the fluoroquinolone and then be able to give them an antibiotic I can use than guess the bug. It looks like Europe and Australia may be stopping this. Is this okay? I was just trying to read online, but I didn't believe it. So, but it's really hard to ethically withdraw fluoroquinolones with the current guidelines out there, even though they're outdated, the guidelines. And then I suspect there's going to be a compromise somewhere between, because we do a lot of febrile neutropenia patients get their chemo go home. I don't know if that's the same here. If after they've on their consolidation chemo, if they're usually on their induction, they stay in hospital, and if they have no problems, their consolidation, they get it and go home. So I understand why they're profoundly neutropenic, why you may want to do that. Getting through Chicago traffic when you have febrile neutropenia, you may not quite make it to hospital. So yeah. But anyone who's on quinolone prophylaxis develop fevers while in hospital, they escalate their antibiotics anyway. So now the duration of antibiotics with neutropenic fevers and no infection. Oh, wow. That's another target I've been trying for a long, long time. The IDSA outdated guidelines are still say continue until the ANC is greater than 500. Oops, I made a mistake there, greater than ANC of 500. The European guidelines say discontinue at 70 hours without proven infection, or 48 hours of a febrile, regardless of duration. And there's no bacteremia. So one study showed you can save 2 antibiotic days. I'm not sure if you're in hospital for a month, that means a lot, but we need more data. Now, if you've got a proven infection and neutropenic fever, I have no idea. We suspect, and I love that from this person, suspect in quotes that 7 days is fine, but who's brave enough to do that? And there's no good, for Pseudomonas, would you be fine doing 7 days and you're a neutropenic febrile patient and say, I'm just going to turn off the antibiotic? I'm not so sure. And it's just Chicago winter at night. So this is the case I'm talking about with resistance. So this young man was 29 years old. He had a large T-cell lymphoblastic leukemia with a massive, big mass in his chest. He was induced at an outside hospital on wrong therapy and had complicated care, and eventually was transferred over to us for better care. He had a tracheostomy placed that was colonized with carbapenem-resistant Pseudomonas, and he frequently got collapse of the lung and infections and needed treatment. He was given his 4th dose of hyper-CVAD in hospital and was sent to a long-term care facility, which is, I don't know if you've ever been to an American long-term care facility. It's not somewhere you want to be. And they sent him out on levofloxacin, fluconazole, and inhaled tobramycin for this carbapenem-resistant Pseudomonas. We weren't involved. He was readmitted from the long-term care facility because his heart rate was 190. He had fevers to 39.5. He was hypertensive. And he came in and he was started on empiric marker of meropenem, vancomycin, daptomycin, and micafungin. We already knew he had carbapenem resistant. Wasn't flagged in the chart, and so they did not see this in the emergency room. So already starting behind the ball. Then they get a call that it's growing gram-positive coxsackie chains from the long-term care facility. Now their lab was an outside lab. It's actually a private lab that they send it out to, not a hospital lab. So he was admitted to the ICU, still in shock. So they added empiric amikacin. No one called us at night. We were always available. They couldn't have called us. And so at 9 a.m., my fellow says, oh, we've got this patient in the unit. And we go, and it's now 18 hours since he's been admitted, since he started his shock. We come in as like, well, we know he's got a previous resistance. Let's start ceftaz-AV because if it's the same Pseudomonas, we knew that was susceptible just 2 weeks earlier. And we stopped the daptomycin and amikacin. And then when I get back to the office after rounds, we get a call that they made a mistake at the outside hospital. It was actually a gram variable and that it's actually Acinetobacter. So I am now like, oh, well, ceftaz-AV is not going to work. So we called for cefderichol, but this is what his final antibiogram came out. We asked for the cefderichol and the tigecycline later, but I'd never used tigecycline for bloodstream infection. They seem to like to, but yeah, it was resistant to every antibiotic, even sulbactam, colistin. Just a week in a long-term care facility, pick this up. Doesn't take much. When I got that result, I switched to cefderichol, got our pharmacist on board. And it took more than 4 hours to get the first dose because it wasn't available. It's not on, we don't keep it there regularly. There's now almost 30 hours from the time of his sepsis and he ended up dying. So yes, he had a terrible lymphoma, probably wasn't going to survive that, but we were doing a formal review. What was the problem was the gram stain gave a false bad result. They'd had people focus on gram positives, which usually aren't that bad in comparison. Would rapid ID have helped? Yes, we have MOLDI, but a lot of centers have blood culture testing where you get a result back in 30 minutes now with resistance markers. And so that was where I was in Portland. We don't have that in Chicago, but we could get a result back in 30 minutes that tell you, oh, it's Acinetobacter. We've never had Acinetobacter in Portland, but would tell you if it had a resistance gene, an NDM or anything else like that. There was no alert in the EPIC chart to say this was a carbapenem resistance prior. Had MRSA there, but no, they hadn't updated it for the carbapenem resistance. And what about the use of amikacin resistance? That's like giving monotherapy aminoglycoside, which is, didn't work much in the 60s, let alone now when you've got a failing patient. And so I would prefer that they started beta-lactam inhibitor, one of the new classes, but that's viewed as costly from the hospital viewpoint. And this is the debate. I don't know if you know the latest CLSA guidelines that are coming out that removing amikacin is just a urine-only drug and gentamicin is being taken away. So,
Can I have to talk about this one?
Yeah, with our febrile neutropenia guidelines.
Yeah, arguing why they wanted to suddenly introduce amikacin when
I've been arguing this for a long time.
yeah,
Yeah.
it's really challenging.
It is. It's this false belief and the data doesn't support it. Yes. Yeah.
And you won't even ship it.
No.
No. I'll show you the data from CLSI because I'm on the committee there. So this is our debate. I'm showing ESBL infections have gone up. They went up pretty rapidly, 5% to 25%. This is all coming from our community. They're just driving it. It's quinolone hell out there. They won't stop. And so we're a referral hospital. So we get all these patients and they're coming in like crazy. Our cefepime susceptibility as a result is decreasing. I don't trust it at all. Pip taser, you know, so we're using a lot more carbapenem, but our pseudomonas rates are going up because of resistance to carbapenems too. So we're running into this cost issue. And so when you go back and look at this is from the Breakpoints Committee, I stole their slides. So if you're wondering how I got this, the current breakpoints were established before 1980, before there were any standards. Okay, so I wasn't even in medical school then. Resistant breakpoints were influenced by concerns of toxicity, not based on efficacy. So they're not actually telling you that these are good breakpoints to treat anything. They're good breakpoints to stop you losing your hearing or your kidneys. And the concerns raised back then were that the achievable serum levels, among other points. And so they're worried about the breakpoints established primarily based on NIC distributions were bimodal and cut through a lot of the breakpoints. And so this is straight out of the slide kit from CLSI. Even if you give the extended interval, current breakpoints were 16 until this year. You don't reach enough to treat any pseudomonas at that dosing. And I don't know whether you do 30, which is the European ones or not, but even then it barely makes it. And so they thought about dropping it down to 1. And yes, you still lose some, but at 1, you're not going to be able to treat many infections. So this is something that's sort of, it's hard to fight, as you know, but it's hard to say that it's a good drug in the long run. And so CLSI removed gentamicin, which I agree, but it's never really effective drug. We're taking it off our formulary right now. To increase tobramycin dosage to 7 mg per kg. Amikacin is now only for urinary tract infections, which is our ICU is going crazy with. I know educators having a hard time. But when they did this, the concerns were a worldwide phenomenon. And so, but there's a lack of effectiveness is the biggest problem. And yeah, convincing people have been doing something that may not be working is a challenge. Which gets to our final point, which the major barriers is resources, you know, lack of clinical pharmacists, ID physicians, IT support, getting good data. Carlos gets great data for us, but it takes him a lot of hours. And to get valid data, especially when there's no trials, acceptance, and as we just talked about, changing practice patterns. And then inertia, it's just so easy to just continue what we're doing rather than changing things. And I was a chair of an IRB. We need to get our patients involved in some of these decisions as well. I've been trying to get on stewardship to have at least one person from the community who may be interested, because they can go out and be an advocate, a voice. And after COVID, everyone doesn't trust us anymore. And so to have a patient voice and say, oh, we're doing this because, if you're on the IRB, you have 2 people who are non-clinical, because they ensure justice and beneficence. And it's really important. As a chair, I found that the VA was wonderful to have them on, because they say, well, why is this group getting this and the other group not? When it just seems so random. So I think we need advocates on our programs, on both the committees for both the transplant and the stewardship programs. And it will help reduce harms and disseminate the information. So in 2023, it's time. We need a team approach, an implementation mechanism, both locally and nationally, both here and in Australia and in the US, to get more data. we need to define our immunosuppressed hosts and come up with some proposals on timelines on how to best manage them. I mentioned cell-free DNA and other biomarkers may be useful in some of these metrics. Recommendations for antibiotic use, standard studies and outcome metrics. I didn't get into door analysis, but I think that's one way to go. Advocate for resources for support this mission. Yes, we need a lot more money, but we come from the poor side of town, infectious disease, and recognize the continuum from heavily immune suppressed immune tolerance in the processes. So this is my team. Una Ree is, she does infection control for the bone marrow transplant unit and helps with all the guidelines up there. Dr. Santos, Carlos Santos, he does all the data collection analysis. As Eric Biomir just came from Mayo Clinic, he's doing the education guidelines, so he brings in all the new, reviews the literature and modifies things. And Haley's our ID pharmacist who helps us out with everything. So the answer to the case was disseminated histoplasmosis. I know we're all thinking TB. We have them all in TB isolation because it all thought was TB. I wasn't on service. They were treated with ambisome for 3 to 4 milligrams per day. I really like the new single loading dose mechanism that we for Cryptococcus, but everyone else is very scared about that, even though it's much more effective. I changed them all to itraconazole when it came on service. They were doing great, and the other one got isavuconazole because it's some CNS, and both recovered quickly. The one with that lung mass and cavity, I saw him like in clinic before I left. He gained 20 pounds and feeling well. So I hope you like that. I know I probably went, oh, I'm under. I was worried I was rambling there. I'm tired. And yeah.
Thanks, Graeme.
Nice.
So that's your talk now. So I
Yes.
guess we've got some time
For
for
question.
discussion.
Yes, I was.
That's great. Yeah. You raised a lot of points that, we're also grappling with. I guess maybe I'll ask Alex to give a brief update on the NAPS. I know Anna and our national antimicrobial audits.
Yeah.
So did you want to
So
say,
Graeme, I guess Australia is a little bit luckier than we, because I know in the States it's very hard to get a national approach to anything. Every site is individual, and you've got your insurers and your privates and the VAs, and you just cannot get any consensus on anything. So
And Epic sells us our data back.
yeah.
You
So-
can't get your data. You
Yeah,
actually have to
Yes.
spend $1 million to get your data back. So
Exactly. So we do know the environment that you're working in, and Australia, I guess, was fairly forward thinking that in 2013 we established a set of accreditation standards for stewardship that are very granular, the most granular that I've seen anywhere in the world, and that are even more granular now. So it's been going for 2013, which is a major driver, and it actually applies to public and private day surgeries. Which is very detailed. We have to measure appropriateness of use, so not just volume. And I guess
that's huge.
which is massive. So I know that Miranda's selling in Ontario, and so Canada has been using the MAPS actually in the transplant population, and we're keen to expand its use because it is very meaningful data to come down at a prescriber and patient level and drug indication level, because you can only use that sort of data to change behaviour. So in Australia, the National Antimicrobial Prescribing Survey platform, which we have a surgical module hospital and an aged care module, and Anna has been developing an antifungal model, which includes outcomes.
Yep.
So we can not only look at prescribing policy, but also measure outcomes, has been a very important national thing. So we have for every principal referral hospitals, 2% of all hospital public beds are audited each year. 500 hospitals benchmark. This is big data that we're now starting to explore opportunities around data science methodologies to how we can use it. And not only that, but it appears to be very translatable and generalizable. So it's been adopted in LMICs in places like Canada and the UK and Europe. So we feel like we, in some ways, are quite ahead of the US and where we've gone to, because the US approached it because he had all the EMRs. They thought they could try and do everything from an EMR, but you can't.
No,
because
you
it's
can't.
rubbish in, rubbish out.
Yes. Yeah.
So you actually have to have some sort of audit feedback process that is meaningful to prescribers, otherwise they just ignore it. So we've used that to drive some of our behaviour change and implementation studies to be able to do that. And that's actually taken contributions by thousands of auditors in Australia a year. And then it's sort of become part of the annual thing that they do this thing. It's voluntary.
Yes.
It's not mandatory.
Wow.
It's actually completely voluntary.
If it's voluntary, nothing would ever happen.
Yeah, so voluntary, but they do it because it's meaningful. And so, and I don't know if Abby Douglas is online, but
Yeah.
Abby's on.
Is Abby there?
Is Abby on? Is Abby on?
I wanted to talk
Abby,
about
go.
AI, but because the EHR is so bad,
Yeah.
it'll create even more
Well,
problems.
and possibly talk about what you're doing there.
Abby's got something as well.
And Abby.
Oh, sorry. What am I talking about?
Your discussions around, measurement and understanding what's happening. Abby Douglas was one of our PhD fellows, our postdoc. She undertook the first ever RCT with PET-CT versus the CT only, or to support stewardship in the high-risk hematology population. So I might open out to Abby to say that.
Oh, thanks, Kaz. Hi, Graeme. Sorry I missed some of your talk. I'll have to watch the recording later. I had an emergency meeting. Yeah, so essentially the Pippin study, as Kaz mentioned, was a randomised trial in those acute leukemic patients and bone marrow transplant patients with expected prolonged neutropenia, who, if they did have what we called persistent or recurrent neutropenic fever for at least 3 days, not resolving on standard empiric antimicrobial therapy, to be randomised to PET or CT to look for a source of ongoing fever and to rule out important differentials like fungal infection and whatnot. And essentially, the primary endpoint was change in antimicrobial therapy or rationalisation of antimicrobials, and we found that PET led to more likely to reduce the spectrum of therapy. So say if the patient was on meropenem plus or minus vancomycin, they were more likely to cease the vancomycin and downgrade to tazocin or even augmentin. And they were also more likely to cease therapy. And we also found kind of as a other side, secondary outcomes, that are less likely to have further investigations and more likely to be discharged sooner in PET. So it kind of seemed to put a bit more of a full stop on the ongoing investigation and kind of concerned about undetected infection and led to more downgrading of therapy. And conversely, in CT, actually, it was more likely that you're actually going to upgrade to or to broaden therapy. So the kind of entirely opposite direction of antimicrobial change. So that was quite nice to see. And I think that's something that can be helpful in that patient group. But I think that there are the two different kinds of groups that we look at, and the other group that we're going to be looking at now is the patients who settle down nicely with antimicrobial therapy, and the question of early de-escalation and early cessation of therapy in those stable patients.
But these are the quality of studies we need to sort of help us out. I have to get a prior authorization if I want to do a PET scan from insurance for an inpatient, because they're only seen as an outpatient test in the US. And so it's amazing that you can do this where I have to.
Yeah, it's interesting, Graeme. We actually, what I didn't mention was that we recognise the challenges, particularly in certain overseas that people face, and so we have performed a health economic analysis of that kind of diagnostic algorithm in the Pippin study, and found that it was cost saving. So it was better outcomes and cost saving. So in that golden quadrant of better outcomes and cost effective. Obviously that's in an Australian funding model, so that whether that applies to the American setting is different, but I guess it still helps to build an argument, and that's been submitted for publication, so we'll hopefully have that published soon in one of the hematology or BMT journals.
No, it's costs are so siloed, and I'd love to have rapid testing. All the costs come from a different center, and so I'd love to have these abilities, but it's not an integrated approach. It's they try hard, but it just doesn't get there sometimes, and so having the solution is really always helpful. I think we need anything that can actually lessen the number of CAT scans we can do. One PET scan over 3 or 4 CAT scans would be so much.
That's right. Yeah, we did find that in Pippin actually, was that the less likely to do another pan scan kind of phenomenon. So it definitely plays out.
And I do want to talk about how you're using EPIC data and setting up some automated surveillance using AI.
Sure. So we are extracting data from the EMR around microbiology results, histopathology, imaging scans, antifungals, prescribing, and trying to apply natural language processing algorithms to flag, I guess, patients that likely have an invasive fungal infection from a surveillance perspective. It's not about prospective and starting earlier therapy. It's more about retrospective surveillance. And we're making really good progress there.
Yeah.
So the intention is essentially to have we've used an implementation science approach with co-design with our hematologists at ID infection prevention to make sure that the dashboard they're going to get eventually, they'll understand what the breakthrough rates are like in all these complex, new patients, because we don't have the data. And they need to understand if there is a problem, what they're going to do, and whether they need to modify our prophylaxis approach. So it's sort of very, new, but I think pretty groundbreaking, because we already know the performance of NLP across written CT reports and histopathology reports is actually performs really, really well.
Of course.
And the manual labour required to do a fungal audit, it is really large. It takes hours. So we think that, we're yet to see, but we're making good strides.
I think this whole area is ripe for AI. It's so easy to program neutrophil count, prior cultures, prior imaging.
Not easy, but
But compared to
AI
general populations, you can really, we've got much more structure.
The AI people always burst out laughing when people say things like it's just so easy to get. Oh, there's bladder. Yeah, you laugh, don't you?
Yeah, well, because I think there was a major bottleneck with the data quality. And information extracting data from every zero. In the neck, and I don't know how it works for you, but for us, every hospital works with different pathology clinics. Every pathology lab has their own way of.
I said it should be.
It's fascinating times. And these little details are the ones that are really difficult to generalize. Kind of once you develop your algorithm, one hospital, one lab, is really hard to generalize it to another institution. It's kind of, you don't expect that when you start a project. You hope it will just naturally expand to at least to the whole state, maybe. But there's a lot of data manipulations and cleaning that comes into that.
Chicago, there's 4 major teaching hospitals, 4.5. And then there's another 50 small community hospitals, and none of them are connected very easily, and so it's always a challenge. As you said, they're all on different systems and different platforms. The EPIC on Northwestern is different to the EPIC at Rush, but we can at least see what data they have. I can, someone gets referred over, I can at least see what they've done. Where if someone's come from another hospital, I can't see anything, and then I have to call for cultures, and I'm spending a lot of time trying to get the cultures I need from those hospitals, which doesn't make sense in 2023. Or I get a CD given to me, which I call the frisbee.
Victoria, yeah.
Because there's no one has CD drives anymore, and I'm like, well, what am I supposed to do with this? Play frisbee with
I
it?
think some states in Australia have been more visionary than others. So New South Wales is probably the one that has said we are having a statewide epic build. They're moving, they're dropping all this and it's going statewide epic and doing a big bang, you know, like not over 10, it's not going to be big bang, it's going to take 10 years, but they're planning that, whereas Victoria still is in that situation where they're just like really different hospitals, different systems.
State of Oregon, everyone was on Epic. It was so good. And that's, I did a whole statewide antibiotic stewardship program there in 2013. I went to every hospital. That was, you know, even the tiniest hospital, they were like beautiful and they were all engaged, and we could show a way of intervening. We're doing remote monitoring of hospitals like 600 kilometers away. They could just call in. It was really interesting. One hospital that had an emergency medicine doctor from New York City, and relative their antibiogram, their MRSA rate was like 2%, and their E. coli was 100% settled every antibiotic, but their standard antibiotic was meropenem vancomycin for everyone. And it's just like, because he came from New York, it was really different.
The other thing I just wanted to flag is a lot of work that was led out of Peter Mac really, and that was to bring sepsis and AMS together. So typically people that do the AMS are not the ones that are actually implementing sepsis programs. And really for these patients, they really are at the front line when we talk about sepsis. So designing and embedding an AMS-led sepsis program and designing and leading AMS delabeling programs, Jason Triviano's work, I'm not sure it was online. These have been two really big areas of research and implementation that have been highly successful and been scaled. So I'd be interested to hear about what's happening in your organisation around sepsis and how you.
Everyone gets labelled sepsis. So even if they're hemorrhaging, they're labelled sepsis. Because EPIC will tell them it's sepsis, and you know the blood pressure's low, and it doesn't identify that their hemoglobin's gone from 13 to 5. But yeah, it's a driver's mark, as a payment requirement. So everyone gets sepsis is, you know, very early treated there.
You use that sepsis for.
EPIC shows that. I don't know, when I open the chart, it will just tell me this patient is septic, are you doing anything about it? And so
This is the one that lists 67% of patients who actually really septic.
yes. So yeah, and often you look and it's just because they're bleeding out. So but yeah, it's there. It's a target, and because it's payment, Medicare reimbursement, hospital reimbursement. CMMS is the big, and they say you have to have antibiotics within 4 hours. Doesn't say it would be right antibiotics, but yeah.
Just, are there any more sort of questions or comments? Because we probably had a very nice discussion, but I don't know if anyone online, I can't see if anyone
There's
has
no comments.
There's
got
a
any
chat.
comments or questions.
I use Twitter a lot, so I'm going to take a photo of the room. And so, thank you. There's a bit of Melbourne in the background.
Yeah.
Sun went away.
Perfect timing with the food. It's just